Hi and welcome to another episode of Coding Matters. In this particular episode, I'm joined by Bridget Kelly. Bridget, what do you do and why is coding so important?
Andrew, I work in the Central Department of Health in a team called the Activity-Based Management and Funding Unit. And so our remit of work is overseeing and providing input and guidance into the funding process that underpins all of our health services across South Australia.
That sounds kind of important.
It is, yes. It's also quite unsung. So we're really happy to be here today to provide a bit of advice and myth-busting and information about the work of activity-based funding and specifically my remit, which is clinical coding.
Great. So we've got three myths here, so maybe I'll state the myth and then you can tell me why it's a farce.
Okay.
So myth number one says each ICD-10-AM, and that's the International Classification of Disease version 10 Australian modified version, has a dollar value attached. We'd like to talk about dollar values in Coding Matters. There are certain diagnoses that attract higher funding when documented in the health record. That sounds right to me.
Andrew, that's a myth. There isn't actually any dollar value attached to individual codes. As you've covered a little bit in your previous presentations and videos, what we see instead is that the dollar value is actually attached to the DRG, the diagnosis-related group. The role that codes play is that they are calculating and adding complexity to the DRG, and the sort of general rule that we follow in health funding and a good sort of rule of thumb for clinicians to follow is that the more complex the coding, the more complex the episode, and the higher level of funding that episode will accrue.
Okay, that makes sense. So there are potentially many ICD-10-AM codes that contribute to the complexity of a DRG.
Absolutely. And another sort of follow-up question, often the first question we get from clinicians is, just tell me what are the codes that will bring in funding. Just tell me what to document and I'll write it that way and then you can get the better funding for the health service.
That sounds simple.
It does sound simple and the intention's there, but with health funding, nothing's ever that simple.
Okay.
And so what the clinicians will often ask when we sort of inform them instead that what we're looking for is complexity, is that they just want to know what are the really complex codes. And it's not even that simple. The way that our health data classifications work is that a code in one episode of care could contribute greatly to the complexity. The code in another episode of care could contribute barely anything. So it's really difficult to actually pin down what is complex, what isn't. And I don't even think it's really a productive way to think about improving our documentation and health data. I think the better way to think about, if you're a clinician watching this video at home and thinking, I would really like to make sure my documentation is bringing in the best funding for the health service because I've watched previous Coding Matters videos and I know it's important. Don't try and think about individual things. Try and think, there is the clinical picture in front of me. I have this patient, I know what's happened to them, I know what I'm going to plan as their care, and think, am I documenting that as best I can? If your documentation is as complete and accurate as possible, then our coding will be as complete and accurate as possible. What that means is it's going to sort of implicitly just bring in all of that complexity, and that's going to improve our funding. It's going to give us the appropriate funding for the episode.
It's almost like you're saying, rather than going back to and trying to remember, oh, in this DRG, this specific complication will add a lot more weighting. It's better to think broadly of the principle of how can I be explicit, how can I be specific, how can I be relational in the way that I'm documenting the different conditions, how can I use more and more specific diagnostic terminology that will give the best chance of being coded accurately.
Absolutely, that's exactly right. That's sort of the platonic ideal of clinical documentation.
Right. Let's have a look at number two. This one says, MBS item numbers can be used in place of clinical documentation of interventions specifically and are sufficient for coding purposes. That sounds quite efficient, right?
It does sound quite efficient. Tragically, another myth.
Oh.
The thing we need to bear in mind here is that MBS, which is the Medicare Benefits Schedule, isn't designed to capture activity like coding is. What the MBS is essentially a big long index of every health service that is going to be subsidised by the Commonwealth government. So Medicare eligible services essentially. And like I said, it's not capturing hospital activity. Coders aren't using MBS when they're coding. We have our own separate classification to capture interventions that is sort of a companion to ICD-10-AM. So we have something called ACHI, the Australian Classification of Healthcare Interventions. And so that's what we're using. And I prepared an example in this presentation. We can see, I've got an example here of the colonoscopy. to seek them. And so on one side we have the MBS item number, and this is the definition that's applied as per the MBS. And then we have the intervention code, which is what coders use. So this is representing the same clinical concept and the same intervention. And so as you can see, the MBS item number has all of these details. It's talking about the indication, which as you can see, it's got a huge range. Positive fecal occult blood, iron deficient anemia, perhaps an abnormality on diagnostic imaging, whereas the ACHI intervention code, all it's saying is that a colonoscopy was performed. So if all that's documented by a clinician is that MBS item number, all we can code is that ACHI 32090 code. And so all of that information from MBS is essentially lost in the wind. It doesn't translate over. And so what we look for instead as coders is all of that clinical detail that's captured in that one MBS item number actually being documented in the record sufficiently. And a lot of this would be on something like an operation report. There might be a little bit in notes and also a discharge summary. So that ACHI intervention code is going to capture what code was performed, but all of that other detail we'll need. So why was the patient coming in? What were your findings? Did anything else happen in the procedure? Because another thing that MBS barely captures or doesn't even capture at all is if there was any adverse event happening in theatre, there was a cause to abandon or alter the procedure. We really need that documented as coders because odds are we can code it and it's going to add to that complexity again.
Yeah, I can see that they both start with 3-2, but that's where the resemblance ends.
That's pretty much it.
And there's an element here which speaks to the broad principles of coding and documentation is that documentation and coding is not only for funding, whilst the MBS code is only for the purpose of reimbursement of that specific item without any complexity, and documentation is for much more than that, coding is for much more than that. Activity-based funding is just one part of good coding and documentation.
Absolutely, yeah.
So number 3, only admitted inpatient care is coded, so clinical documentation is not as important in non-admitted emergency care. And I suppose you could even say outpatient care as well. And if you've been watching all our series, you might think this because we talk almost exclusively about inpatient care. Just a little promo, we will be talking about other episodes of care in future. So is this true?
Well, this is actually a half-truth, I'd say.
Okay, I thought you were going to bust that one big time, and you surprised me.
Well, the first half of this myth is true. Only admitted inpatient care is coded. So the other types of care you're talking about, ED care and outpatient care, we still capture quite a range of data for these episodes, but it's not to the same level. So we do actually record a principal diagnosis in emergency department episodes, but there isn't any of those additional diagnoses or interventions that coders are looking for in inpatient episodes. We just don't go, we call it that granular in our data for ED, and outpatient data is recorded in a different way again. However, the clinical documentation is just as important.
Good to know, good to know.
Yes, in our non-admitted emergency care episodes. Coders they'll be looking primarily at the inpatient episode clinical documentation, but they will look back further to gain further context. They'll be looking for things like referral details. In the case of emergency department episodes, quite a common pathway is for a patient to present to emergency, spend some time there and then be immediately admitted to the ward.
Sure.
So it's considered sort of a flow-on of this overall inpatient visit. And so the ED documentation will capture all sorts of things. One thing that coders are looking for with every diagnosis, and this previous ED data can be really informative, is the time that a condition is onset. This plays a really important role in determining whether a diagnosis is something that a patient presented with, or if it's something that's actually onset during the episode of care. And conditions which onset during the episode of care can very often trigger a warning that this is a HAC, a hospital-acquired complication.
Yeah, we talked a lot about that previously.
Absolutely. And so if you took a scenario where, say, a patient's admitted into from the emergency department, and several days into their admission, they're diagnosed with a UTI and a treatment plan's drawn up. That's relatively straightforward. What's going to make the difference here is when that onset of the UTI is first documented, because a UTI that's arising during an episode of care triggers as a HAC, and so there's going to be a funding adjustment. And so there's going to be a bit of funding taken away from the health service because that UTI has arisen during the episode of care. It's a safety and quality check. And so what a coder will look for is at the start of the ED presentation, when a patient's first presenting, were some of those symptoms documented
Sure.
by a nurse or a doctor? Perhaps something, just documentation as simple as query UTI. That can make the difference in a coder saying, actually, this timeline is much longer than we thought. It's something that a patient's presented with, so it's not something the hospital could have prevented. It's actually a condition that we're still going to treat, obviously, but there's not any safety and quality implication for the hospital. It's
Sure.
just part of their care pathway.
Yeah, that makes sense.
The other thing that ED information often gives a coder, which isn't present in inpatient documentation, is a lot of this important contextual information. So I'm talking about things like if a patient presents with an injury, there's information such as the mechanism of an injury, the location where a patient was when they sustained an injury, and the activity, what they were doing when they incurred an injury as well. This is all data that we can code. It's really important for statistical analysis and injury prevention. A lot of it can be used to assess sort of incidents of workplace injury, things like that. So this information, what we typically see is that when a patient presents to ED, if they're brought in by ambulance because they've, broken their leg at work or something, all of that the entire incident is going to be documented really clearly in the ED episode because it's the first point of care. They're probably going to get a handover from paramedics. The patient's going to report everything that happened when they're admitted later to the ward and they're receiving, care in the orthopaedic ward or something. It's less likely all of that's going to be duplicated again. So the
Yes.
coder will refer back to that ED documentation to make sure they've got all of those important details which sort of provide a context to a patient's injury. So
Yeah.
that's just a couple of the ways that we're using ED documentation as well.
Yeah, and that makes sense. We've talked recently on our trauma video about that very issue. And in multi-trauma, it's so important to know what are the clues where an injury might have been present but just not diagnosed at the time of presentation to the hospital, what care was provided prior to attending the hospital, as many of our patients come to emergency having already had some treatment or assessment in the community or at another facility or by another professional. All of those things add, and as you say, once they're actually admitted, the focus becomes management of the injury or the diagnosis and less on the circumstances leading to that presentation.
Yeah, absolutely. It's all about getting that complete picture and sort of the whole sort of context of the patient journey. That's what we're trying to capture, all of the hard work that's being done in our health services and abstract it into codes so we can submit it and get funding for everything that's happening here.
Great. So at the end of the day, it seems like we've come back to very similar principles about being explicit, being specific, drawing very clear relationships, saying, this has arisen because of this, due to this, secondary to this, rather than saying things like on a background of. Those things don't have that relational element. And being really clear, even if we're expressing a degree of clinical uncertainty, saying likely or probable or possible are terms that we can use a lot. That's stuff that's really important from your perspective as well?
Yeah, absolutely. So all of this information, it's just providing all of those little links between diagnoses and the care that's provided, and that really empowers coders to actually code what's being documented, because we have quite a rigorous set of standards that we need to code to, so we can't actually make an assumption about a diagnosis. So we really need that evidence, even if it seems really painfully obvious to you as a clinician. Making those connections is actually really important because then we can code it. Something really important to remember for coding is that it's done retrospectively. We weren't there, so we're relying on the narrative that clinicians are writing for us.
Yeah, that makes a lot of sense.
And so these points in this presentation are actually points that Andrew's made. These are some really great tips from previous Coding Matters videos about ways you can start to improve your documentation practice and adjust your thinking, making sure are you getting your clinical reasoning process and the diagnostic conclusions you're making, getting those onto paper or on screen if you're working with an electronic medical record. Ultimately, we want to have really great high quality clinical data, and to do that we need quality clinical documentation, and that lies with our clinicians all across our health services. So, in summary, clinical documentation is the basis of our health data, and this health data informs not just our activity-based funding, but our performance benchmarking. It's the basis of research, and future health service planning. There's so much work that we do with our health data, so we're really looking for it to be as good as possible, and to do that we need our documentation to be as good as possible.
I've had people often say, I'd like to learn more about this. Where are the resources that people can get this, whether they work in SA Health or maybe outside?
Andrew, there's a few different places that you can look. So our team within the Activity-Based Management and Funding Unit is called the Medical Records Advisory Unit. That's what Rachel and I are positioned in. So this is the source. Unfortunately, it's only available for SA Health staff because it is on our internal intranet, but we've developed a range of resources around subjects such as hacks and clinical coding, some details on episodes of care, which I know is an area that is of interest for one of your future videos. There's all sorts of fact sheets and resources there for people who wanted to get a bit more information for themselves or if they want to distribute anything further. If somebody's after the really technical information, like our price weight tables, technical specifications, the best place to go would be the Independent Hospital Pricing Authority website. That's ipa.gov.au, because they're sort of setting the standard of all the work that we're doing, and so all of this information is publicly available as well. Like Rachel said, they really operate on a mandate of transparency, so all of this information is available for anyone to access and download at any time.
Wonderful.